Hi everyone, and welcome this afternoon to our final webinar for the year with Orygen, the National Centre of Excellence in Youth Mental Health. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would like to also pay my respects to elders past and present. It's my pleasure to introduce Simon Rice today. So Simon is a clinical psychologist and a research fellow with Orygen, the National Centre of Excellence in Youth Mental Health. And he's both a clinical and research interest in men's mental health, mood disorders in young people, and e-mental health interventions. His PhD focused on the assessment of depression in men, and the key outcome of which was the Male Depression Risk Scale, which is a validated multi-dimensional screening tool for assessing externalizing symptoms associated with distress in men. So Simon has clinical expertise in forensic and inpatient settings where he worked with men experiencing combat-related trauma and intergenerational disadvantage. And he is co-leading the development of ethical guidelines for working with men and boys in mental health settings. He's a board-approved supervisor, and he's also a clinician at the Youth Mood Clinic at Orygen Youth Health. So that last point's probably the most relevant, along with some of his research work for the presentation that he's doing today. So he's going to take you through an overview of the treatment model at the Youth Mood Clinic at Orygen, particularly looking at how this model is used to manage persistent or severe depression in young people. So we know that we've got quite a lot of people joining us today, which I think is indicative of the interest in this area of how we can think about to effectively manage young people who have a high level of need because of either the duration or the severity of their depression symptoms. So I also wanted to welcome international audience members as well. So we will welcome all your feedback and questions, and we'll make sure we do get time for them at the end. But now it's my pleasure to hand over to Simon, and then I will help facilitate the questions at the end of the webinar. Thanks.
Thanks very much, Alex, for that warm welcome. So great to be talking to you today about the work that we do here in the Mood Clinic at Orygen. So as a way of an overview of what we'll be covering, a bit of a background of what complex depression looks like. I'll flag where some resources are available because that's what busy clinicians and researchers tend to be most after. And then talk about the different components of the treatment model as it stands when we work with young people with complex depression, which will include a little bit of coverage about antidepressant medication, supporting families and caregivers, and then how we think about managing ongoing or chronic suicidal ideation, and finishing on self-care. So to start with, it'd be good for me to get a sense of the current settings in which our audience is working in. So I've got the treatment in brackets because I know not all of you will be working in treatment settings. But if you could just tick one of those boxes and then submit on the quick poll, which I'd imagine you can see on your screen there. And do we have answers for that one?
We've just got about the last couple coming in, Simon.
Okay,
so
great.
About 80% have responded.
Thank
we'll
you.
Just give it a few more seconds.
Okay, so it looks like most people are based in child, adolescent or youth mental health services. A smaller group, 11% in adult, 11% in headspace or enhanced primary care, 24%, so about a quarter of our audience in primary care settings, and a significant bunch of 8% who are postgraduate students who are on placement. So welcome to all of you, it's great to have you along today. So as we go through, I'll be covering some of these resources. So I've made, just displayed the slide with some of the content that we've been developing in the Mood Clinic over the last few years. So should you want any of these, please just drop me an email. Many of them are available open access anyway, and my email will be on the final slide. And so they talk through the treatment model that we use, how we work with families, when we work with young people with complex depression, and also our model for working with suicide risk. And the document in the top left corner, that's our treatment manual. So it's got an interesting history. It initially made to support a randomised controlled trial, which I'll talk about briefly at the end. but it's very detailed. I think it's about 120 pages that talks about the various components, and it has a lot of resources, and that's available for purchase through the Orygen campus website. So a little bit of background information about depression. So we know it's the leading cause of disability in young people worldwide. Tragically, suicide is the leading cause of death for young Australians, and we know that mood disorder is a major risk factor for suicide as an outcome. Depression is highly prevalent, and it's most likely to emerge in younger people, so before that age range of about 24 years of age, hence why we've got this kind of critical period in which to intervene. And so we're really keen on focusing on those years, in particular between, say, 12 and 24, 25 years of age. We know that depression is also a highly remitting disorder, so if we can give people the skills that they need earlier on in their treatment experience, they're likely to offset future episodes. We also know that depression has serious adverse effects on functioning, and that can include social, education, vocational or family functioning, and all of these domains are very significant to the lives of young people. So we also know from existing data that earlier onset of depression is associated with higher rates of suicide and suicide attempt, and chronic course of depression is associated with other forms of comorbidity and more chronic impairment in functional outcomes. The typical signs and symptoms of depression are fairly wide-ranging, and given the 9 symptoms that are, at least in the DSM, can combine in various different ways, there are over 250 different kind of symptom combination clusters of how depression can present. But essentially we're looking for core domains of emotional changes, feeling of unhappiness and moodiness, but particularly for young people, feelings of irritability. So that's part of the diagnostic criteria for young people aged below 18. Also thinking carefully about cognitive changes, so difficulty with thinking, and often kind of feeling very self-blaming, and then prominent behavioural changes. And so one of the ones that we would see frequently in the mood clinic are young people presenting with self-harm, which we know can be a risk factor for suicidal ideation or suicide attempt. I won't speak specifically about self-harm today. We have other webinars on that topic. And then finally, there are also some physical changes to be mindful of in terms of low energy, changes to libido, and there can be restlessness or agitation as well. When we work with young people in terms of thinking about their history, we usually think in the mood clinic about a 2-year window of what's been going on previously, and we think about tracking things according to a mood timeline. So this is a simple kind of representation of what a mood timeline may well look like. So here there are 3 key events. So the end of the year when everything was good, and then mood starting to decline, where the young person saying they were starting to experience some bullying and felt some ostracism or social exclusion, and then moving on to that lowest point on the mood timeline where their parents separated, and in their words, their mood hit rock bottom. And I think that's a really important one to think about, especially with younger young people who are more in the 15, 16, 17-year-old age range, that family systems factors can have a really strong pervasive influence on mood. So we always think about what we can do to support families, and I'll cover some material on that. We also think fairly relationally in the mood clinic when we're planning treatment, and we draw on concepts not just from CBT but also from interpersonal therapy. And so sometimes it's useful to map what's going on interpersonally in young people's lives when their mood might be fluctuating, and that can be really informative as well. So we'll move on now to give a little bit of a background about the structure of the mood clinic. So the mood clinic sits within the Orygen Youth Health Clinical Program, and that's part of Australia's largest specialist youth mental health service. And we provide mental health services specifically to 15 to 25-year-olds in the Western and Northwestern region of Melbourne. And at the present time, we're across 3 different sites. So we have a youth access team where our triage occurs in an inpatient unit, and 2 outpatient sites where young people attend for outpatient appointments. Within the mood clinic, outpatient care usually ranges from somewhere in the range of 4 to 6 months of weekly sessions. So a young person will be allocated to a clinician who provides psychological therapy, typically CBT, but also aspects of IPT, and they'll also be allocated a consultant psychiatrist or a registrar who's part of the treating team and manages physical health and medication issues as well. So in terms of the cut-off kind of entry criteria, we consider the group that we work with to have complex depression, and we operationalise that as moderate to severe major depressive disorder, typically assessed through a PHQ score of 15 or greater, or non-psychotic bipolar disorder. Most of the young people who come through the clinic would have PHQ-9 scores far in advance of 15, and effectively that's just a measure of depression that maps onto the 9 diagnostic criteria. But that's not sufficient. We also need young people to have at least 2 or more of suicide risk, and by suicide risk we refer to a recent attempt or significant ongoing ideation that would warrant fairly high degree of concern. And we're also mindful of comorbid mental health disorders, and that may include anxiety, personality disorders other than borderline personality disorder. So we have a specialist clinic for that here at Orygen, or autism spectrum or substance use disorders, though we'd really be seeing depression as typically the primary diagnosis of needing treatment. And then finally, poor psychosocial functioning. And it's uncommon for young people who attend the clinic to have high levels of psychosocial functioning, just given the complexity of the symptoms that they're experiencing. We typically work with around about 150 young people per year. That's the resources that we have. We'd like to be able to help more, but unfortunately, within our constraints, that's the best that we can do. So I'll talk now about the broad treatment phases of the clinic. So this is part of a recent paper which I can forward to anyone who's interested, but we've broken the model into 4 discrete sections. So really thinking initially about an initial phase which lasts somewhere in the range of 1 to 3 weeks, then followed by a treatment and recovery phase, which in the best case scenario would range up to 16 weeks. And then a young person would ideally move on to a consolidation and relapse prevention phase, which would give them somewhere in the range of 17 to 20 sessions. For young people who don't respond well or well enough at that point of around 16 sessions, we then move into the continuation phase, which is really a phase of treatment that continues as needed, and that may be far in advance of a few months, depending on the complexity, the amount of risk involved, and the number of services we need to also engage to get that young person feeling well supported. The next 2 slides cover the model in a little bit more detail, and I won't talk too much in detail about the ones that are in blue because there's more content to come on those as we work our way through. But effectively in those first 3 weeks, we're really focusing on engagement of the young person, an initial assessment and formulation, and ensuring that we've got involvement of family or caregiver to some degree. And we see that as being really critical. So when we think about engagement, we are keen to be able to engage the young person quickly, and we think very flexibly about that. So, being a youth mental health service, we may need to think about, phone, SMS contact, making sure that we follow up non-attendance. And we would view non-attendance differently on a case-by-case basis. For some young people, it may be about non-readiness to engage in treatment. For other young people, it might be that symptoms are just too severe or impairing for them to be able to get into centre-based care. So we might need to do some outreach visits in the interim to foster that engagement, or we might need to do outreach visits on the kind of longer medium term. When it comes to assessment and formulation, we want to have a good sense of the depressive symptoms and comorbidities, the severity, frequency, duration of those symptoms, and so we'd be looking at undertaking a fairly robust clinical interview and using screening tools to get a sense of that. At that point, we're also very keen to get collateral information from significant others, which sometimes will corroborate and sometimes it will be distinct from what the young person themselves might be telling us, and all of that's important information for us to be mindful of in clinical decision making. We also then work on a case conceptualisation basis and make sure that somewhere in the fairly early phases of treatment we provide a shared formulation to the young person themselves about how we conceptualise their current presenting problems, and really with the aim of promoting awareness and insight for that young person. And where possible, we try to communicate that shared formulation to caregivers as well, and see whether we can get a shared understanding both from the young person and their family about what has been going on and the reasons for their current presentation. I'll skip over now into the treatment and recovery phase. So somewhere in that range, early on, around 4 weeks, we start to focus more on goal setting. Ideally, we'd get to that earlier, but often it's just not possible due to the complexity of what the young person may be presenting with, needing to kind of manage and maintain their safety and manage risk. So it can take a couple of weeks to get to that initial goal setting, but we really frame that around wanting to shape that treatment to the young person's specific situation and needs. We set realistic and achievable goals. And we think about their broader career and vocation plans. And early on in their treatment phase, there will be a detailed case presentation at our clinical review meeting, where there's an opportunity for the wider clinical team. And it is a very multidisciplinary team, so we have psychologists, we have occupational therapists, social workers, we have psychiatric nurses at times, including our medical staff. So there's a broad array of perspectives in that. Skipping down then to the continuation phase, so this doesn't happen necessarily for all young people, it's more on an as-needed basis, but essentially if a young person hasn't responded well within that first 16 weeks of care, we'd then be wanting to do something to review the episode, assess whether there might have been other symptoms or other morbidity that we may have missed, or what environmental complexity is kind of preventing treatment progress. And often that might be around a complex trauma history or some other family functioning aspects. We then focus more at that stage on functional gains, and so we'd be looking to engage other aspects of the service here at Orygen in terms of the group program, to make sure that young people feel like they have some sense of social goals, social connectedness, and some skill development in a group-based setting. And there might also be a component of referral and ongoing support that's needed. Then heading down into that consolidation phase, so this is where young people who are ending or coming towards the conclusion of their treatment, we'd be thinking about reviewing therapy progress, what needs to be done in terms of this point on in managing wellness going forward, and then medical review and psychiatry review if needed. And then that process of referral back to a community setting, so that might be headspace-based care, private practitioner, or minimally linking the young person back in with their GP. So I'm mindful that there may have been some questions that have come up, so we might check if that's been the case.
Sure, so just interested, first, probably just one about the PHQ-9, people just wanted to know how they could find it.
It's a great question. If you Google PHQ-9, it'll come up. So you can access a Word document or a PDF version. It's a pretty neat screening tool. One of the limitations is that it assesses frequency of symptoms as opposed to severity. So some people don't like it in that regard, but I think it's very useful.
And probably too, Simon, just someone had a query about, just can you give me a bit more information about how you determine if someone's a non-responder? Is that based on depression score severity or lack of functional improvement or both?
Usually it's pretty clear. Sometimes which would seem a bit of a contraindication of the treatment we provide. Sometimes young people get worse. Their situation is such that their symptoms become more severe throughout an episode of care. Sometimes young people just will not improve at all, whether that's based on outcome measure data, so the PHQ-9, or based on their symptoms, so they may still be feeling actively suicidal in terms of having some high degree of intent and planning for an extended period of time, or sometimes they just might remain with a high level of functional impairment, so they might not be able to leave the house for extended periods of time or feel like they're able to engage in something meaningful in a vocational sense. They tend to be the main indicators. Okay, so let's move on to this next part now, which I'll cover very briefly because once again we have other webinar topics I think saved in the campus about medication, but just to mention briefly that it's often the case that psychotherapy and medication is needed to effectively treat depression for young people who are attending the clinic. That's to say not all young people who come for outpatient care are on medication, and when we do think about, or when the medical staff think about prescribing, we convey a hopeful yet but also a realistic message about the effects of medication. So we know from rigorous research that on whole medication is effective, but there are a large proportion of young people who won't experience a significant boost to their mood from it. So while we try to give that message in a hopeful way, but we're also realistic in saying that if there's no response to a medication, we may need to move through once it's been given a reasonable trial. So any prescribing's always done in consultation with the young person, and there's multiple things that are considered there in terms of their severity, of current presentation, previous response. We're very mindful that the research data shows that there can be a small increase in suicidal thoughts in relation to the prescription of antidepressant medication. So any young person who's started on medication or dose has changed will be monitored within a week just to check the impact of that. And we have a medication algorithm that's used, so typically the first stage of medication is fluoxetine. That's chosen because there is unequivocally the strongest evidence for fluoxetine in young people, and then there's other medications that are chosen to go through from there on. Okay, so let's move on now to our work with families, because we see this very much as core business of the clinic. We know that for young people in those years of mid-adolescence and emerging adulthood, there are significant transitions that happen for families in terms of their structure and membership and roles, and often these transitions don't run particularly smoothly, and the family system effectively is left to deal with managing some of those developmental tasks. And so when we work with families, we work from a family life cycle perspective, that things change, that there's an ebb and flow in family dynamics, and that sometimes families kind of struggle, but typically they're always doing the best they can to manage, and so we're mindful of giving that message. And so we're fortunate in the Moot Clinic to have some level of resource in terms of specialist family workers, but it's probably fair to say that a large amount of the family work is also done by individual clinicians. And so we're always mindful that patterns in families are kind of sustained in the system, and we see them as wider than the individual themselves, but we also have the view that families can be very active and powerful agents of change, and so if they're just given the right skills and the right level of insight, that they can often make great changes themselves. And so it's typical that they'll be needed to do some level of strengthening the relational bonds in any of the family work that we do, but where families are over-invested, or maybe a particular caregiver's overly emotionally close to their young person, we might need to give them a message of the importance of separation in individuation as well. So the family work model that we use is pretty much based on this triangle. So every family gets some level of engagement with the service and some level of psychoeducation, and any family who comes through the inpatient unit is provided family peer support by a peer support worker based at the inpatient unit there. And then, as is needed, there might be the need for regular family meetings with the treating team. And then if that doesn't feel like it's sufficient to provide the support that the family needs, maybe there will be a need for some specialised family work undertaken by the case manager or the doctor. But then there can be some cases where the resources required to provide that are beyond what the case manager and the doctor can provide, and so we might need to engage a specialist family worker. So I know that that's not necessarily possible in many private-based settings. So that's one thing. Yeah, there's a point of difference between our model, which is effectively a tertiary mental health service model, and we're fortunate to have those resources. But I think there is a lot of good work that can be done with families regardless, without that specialised resource as well. So we think carefully about some of the developmental factors in terms of family work. So for younger clients in that 15 to 17 year age range, it's often issues around individuation and boundary negotiation and conflict, and managing conflict. That's often associated with suicidality in our cohort. But when we see older clients, so more in that emerging adulthood phase of 18 to 25, some of the family-related issues might be more around major role transitions, completing education, moving into a new phase, relational maturity, and relationships changing within the family dynamic. So young people or their siblings partnering, moving out of the family home, which all of those things, some families manage well and other families manage less well. So we're mindful of all those things. So now moving on to the core components of the psychological treatment that we provide in the clinic. For the most part, we have a CBT focus, but as I mentioned earlier, we also think very relationally, so we integrate concepts from IPT as well. But within the CBT that we do, we break it into two distinct parts. So there's a core module and there's also a targeted series of modules. So our general expectation for a young person who's attending for that 4 to 6 months is that they'll receive all of the core modules at some point. And for the most part, these are your basic CBT aspects. So, you know, definitely always starting with a level of psychoeducation, component of understanding and monitoring emotions, behavioural activation, which I think done well can be incredibly effective in working with young people. And then moving into the more cognitive components, so the ABC model and chain analysis, identifying automatic thoughts, and then as a young person's finishing their episode of care, that would then be moving into relapse prevention. The targeted modules are only used as needed, and so it would be very unlikely that any young person would have an episode of care with all of the core and all of the targeted modules. So they're kind of chosen as is needed. But it's typically the case that there'd be safety planning included in all cases of young people attending the mood clinic. So on the next slide, I'll just give an example of some of the resources. And so these are resources that are available in the clinic manual. And so this is available to purchase from the Orygen campus store. And so as I mentioned, so it's been specifically tailored to work with young people in that age range of 15 to 25 who are experiencing depression. And so some of the resources here are my model of depression. So that's something that we'd use in the early stages of care when we'd be thinking about psychoeducation. We have a standard crisis plan there that we'd use with all young people, and we'd make sure that that's available to their caregivers. There's a problem-solving template there, which is often a skill that needs a little bit of development and honing in young people who we work with, and there's also some activity tracking and emotion tracking sheets there as well. So when this slide should have been up earlier, apologies for that. So just finally, to come back to family work, when we think about young people's preferences, we always are mindful of their consent and family involvement and sharing of information and who's privy to which information. And so we make sure that we get young person's engagement and their permission to engage in family work. And if there's a strong level of resistance that a young person doesn't want their family involved, we usually take that as a fairly potent indicator that the family or the young person may well benefit from some level of connection with the service. But we'd also respect that, and we'd say, okay, well, let's just kind of keep it on the back burner or the side burner, and let's revisit that as we go through our treatment. And usually that's sufficient to respect the young person's wishes, but then if we feel like as a treating team we need to continue to put that on the agenda, then we can do so as well. So at that point I might see if there's any other questions from our audience. No further questions at this point?
No, it's just a question, I think, probably about how to access Orygen Youth Health, and perhaps just to reiterate where we're located and how people can find the service, and whether there's any similar ones that you're aware of in other states, but if not, that's okay.
Sure. So Orygen Youth Health is, as the clinical program, is a tertiary mental health service based in Melbourne. We support young people and families in the northwestern metropolitan area. We have a catchment of, I think, about 1 million people. So unfortunately, we can't provide any clinical care beyond that environment. Our Orygen, the National Centre of Excellence, is a nationally based research centre that can provide resources and support, but otherwise I need to refer you back to your local area mental health service, and depending on where you are in New South Wales, there'd be points of contact for that. Okay, so let's now move more into the area of suicide and managing suicidal ideation, because this can be one of the trickiest aspects to manage with young people who are presenting with complex depression. So kind of at its core is often this problem of hopelessness, and many of the young people that we work with in the clinic will say to us the following kinds of things. There's no point to living, I have nothing to look forward to, I just can't stand life, I'm feeling so miserable that I want to kill myself, it's the only way to escape, I'm a burden to my family, they'll be better off without me, nothing helps, I've pretty much tried everything. And that last one, nothing helps, I've pretty much tried everything, is a very common one that we get, being kind of the end of the line of as being a tertiary mental health service. Usually young people have been through engagement with some level of kind of school support, school counsellor, or maybe support at a university, maybe engaged with their GP or referral to a private provider or headspace, and they've found that those services haven't been sufficient, and then they come to us. So often young people can be feeling even less hopeful about what's going on for them because they might have sought help in the past and it hadn't been effective. As the basis of a lot of the thinking and the work that we do, we build on the work of Thomas Joyner and the interpersonal theory of suicide. And so Joyner's work really captures this part about what is the desire for suicide, what are its constituent parts, and who is it? What are the characteristics of those people who get to that point of having not just ideation but also acting on that ideation? And so the interpersonal theory of suicide, it's a pretty neat, fairly simple theory, but it really talks about two key psychological states, and that's perceived burdensomeness and a low sense of belongingness or social alienation. And so Joyner's argument is if these two factors are in coexistence, there may well be someone who is at significant risk of suicidal ideation or maybe an attempt, because he sees these as being very protective in their nature, and with these goals kind of thwarted, then people, and young people in particular, can be at particular risk. And that's also in combination with this notion of overcoming self-preservation, which we all have this innate desire to look after ourselves. And so it takes a fair bit of emotional suffering or emotional energy to overcome that will for self-preservation. So on the next slide, there's a nice depiction of how the interpersonal theory works in practice. And so in combination with this notion of a thwarted sense of belongingness and perceived burdensomeness, exists this desire for suicide. And in that part of the Venn diagram there where the capability for suicide also interacts, where there can be this learned ability or some ability to then enact lethal self-harm, that's where the actual suicidal act can take place, at least from the theory's perspective. And so I'll walk through a couple of the things associated with thwarted belongingness and perceived burdensomeness. So here are some of the correlates. So the first one looks at belongingness, thwarted belongingness having components of loneliness, and so they're correlating with self-reported loneliness, or negatively correlated with feelings of pulling together with other people. And then the other component is an absence of reciprocal care. And I think often we'll see the effects of this in young people who haven't been travelling well for an extended period of time, and then have the opportunity to look after a pet. And this notion of them being able to provide care for the pet and then experiencing some effective connection to that pet in return can sometimes be sufficient to really lift young people out of that state. And I'm not necessarily suggesting that's sufficient to treat complex depression, but I think this notion of reciprocal care is a really important point, and I think that links strongly to this notion of thwarted belongingness. Now, the other component of the interpersonal theory is perceived burdensomeness. And so if a young person in our clinic starts talking along the lines of, my family would be better without me, I'm a burden to others, they're things that we're very attuned to, because when people get to that stage, it's a significant risk factor. And Joyner saw that there was kind of two parts to that, so a liability part and also a self-hate component as well. So I guess that kind of leads to the question, so as clinicians, how do we work with young people experiencing ongoing suicidal ideation? We know that this is a population that can require significant resource. They can induce pretty strong feelings of clinician incompetence, and they can lead clinicians to feel fairly overwhelmed and burnt out. So based on this and the lack of guidance that was in the field at that point in time, we undertook a project in the Mood Clinic where we were keen to develop a set of practice principles. There's really good literature on what to do in that kind of acute phase of suicide risk, but there was that real gap in how do we manage young people who are presenting with ongoing risk. So now I'll walk us through those 8 practice principles. So the first one is around engagement and consistency of care. So it's really important that a really strong therapeutic alliance is built and a trust is built early in treatment. And so when working with young people who are experiencing ongoing ideation, it's really important to be attuned to any engagement barriers and to think carefully and sometimes even creatively about how those barriers might need to be overcome. And I mentioned before that one of those can often be high levels of hopelessness, and that might not just be for the young person, it could also be within their family, and it could be because they've had many, many different experiences of trying to seek help and not be able to get the right help that they need or the help that's been effective for them. Another really important one that we consider as being able to offer therapeutic consistency. So some degree of predictability and dependability, because often for young people in these experiencing these levels of symptoms, there will be a degree of kind of chaotic nature of their lives otherwise outside. So we're wanting to provide some stability there for them. That can be hard in any mental health setting, and certainly also at Orygen. A lot of our staff work part-time, but we'll set up the expectation there's always support available in some way, shape or form, and so that a young person's able to feel comfortable to access that. Point 2 is managing ongoing risk assessment and documentation, and we see it as being very important to always assess and document ideation. Sometimes young people might get a little bit frustrated that time might be taken up in session asking about how suicidal thoughts are going. Sometimes a nice way to do that efficiently is to use the PHQ-9, so you're kind of getting them to provide their symptoms. The 9th item of the PHQ-9 asks about self-harm or suicidal ideation, and depending on what they endorse on that item, that might be a bit of an entree into a discussion. And typically we'd be focusing on what's changed. So if risk has increased, why has it increased? Do we need to change our safety plan? Do we need to get others informed? And when making any documentation around risk, also making sure that there's some protective factors noted there as well. So that leads into the 3rd point, which is around individualised crisis planning, and really critical with this kind of population to make sure that there is a crisis plan or a safety plan provided, that the young person, people who are providing care to them, whether that's family or friends or other people in their lives, have access to that plan, and also that relevant people from mental health services have access to that plan. And at least in that acute phase, it might mean being mindful about restricting access to suicide means, because we know that that is a very effective intervention. It can be important to communicate to families in particular how long that restriction might need to happen for, because sometimes families will be overly protective and then engage in patterns that, although they've got the best of intentions, can be unhelpful for the young person if a parent might be sleeping in bed with the young person, or all the knives in the house have been hidden, or all the medication's been hidden for months and months and months, and what that potentially communicates to the young person in terms of their own innate coping. So that is a balancing line, but certainly in those really acute phases it might be necessary to do that. Next important point is activating systems of support. So I said before, we think very relationally, and it's really important that any young person accessing care feels like they have some system of support underpinning them. And within that, we might think about providing some family sessions, because family is also going to be a significant support to the vast majority of young people. And we also think that sometimes there's value in having conversations with caregivers at non-heated moments or non-crisis moments about how they can have conversations with their young person about their young person's risk. And if they want to develop skills in asking about suicidal ideation, we might kind of practice that with a family member, though we don't necessarily have any expectations that we see it as their role to do that. We just offer that if that's something that they would like. The next two are kind of quite positive in their nature. So the fifth one is about engendering hopefulness, and it's really important when working with young people who are pretty low on hope that we communicate messages of hope in different ways. So we focus on communicating a realistic and a hopeful message in the work that we do, that we try to remain positive, but we also remain realistic, and so we don't want to be Pollyanna-ish about things, and we also want to be able to validate young people's distress. But a nice way in which we can do that is using other role models who have been through significant experiences of depression or suicidality. There might be peer support programs available in other places in the country, but that's certainly a component that we use here at Orygen. And we engage young people in meaningful activity as well. We ensure that in the sixth point that they develop some adaptive coping, so that's part of that shared formulation approach. And we also work with them to enhance their problem-solving skills, because that's usually an area that's fairly underdeveloped. Then the last two practice principles are around managing acute risk, which it's fairly typical that kind of a chronic presentation or an ongoing presentation of risk can kind of bubble into an acute presentation if there are additional psychosocial stresses added to a young person's environment. And so we'd always see it being really critical to manage those as needed, and it might be appropriate to engage crisis services, increase the frequency of contact, or make sure that there are good supports available, and that the young person knows that they've got people that they can consult with, whether that's a family member or a friend, or perhaps someone within the school system as well. And then kind of overarching all of the practice principles and the need for consultation and supervision, really important point working with this population. As I mentioned before, they can induce lots of feelings of inadequacy, of stress, and sometimes of frustration in clinicians, and so it's really important to be accessing peer supervision or consultation with senior colleagues. So I might see whether we've got any more questions at that point, Alex.
Sure, so I just wanted to know a little bit more about peer support worker, just to maybe if you could describe that role.
Mm-hmm. So peer support workers can be available in different settings, and many hospitals, tertiary health services certainly have peer support workers. So we're talking about, in this context of young people, a young person who has a lived experience of depression, of suicidality, who's engaged in treatment, has found that effective, and then undertaken some training in a peer support role to then be able to provide support, kind of that hopeful message to other young people So their role's not so much therapy-based. There's no expectation that they're clinicians or they have health training, but more to provide that experience from someone who has been there, who's been through it, and provide that kind of hopeful message.
Great. There's a couple more, but I think we might come to those at the end.
Okay.
That's all right.
Yep. So we'll move through the rest of the content fairly quickly. So we've got 5 or so minutes for questions. But as we finish up, I just wanted to highlight that it's really important in this work to focus on self-care. So clinician self-care is typically something that's not well covered in any of our training programs, but I think is something that's really essential if we want to maintain the kind of work that we're doing in this space. So an example of some of the factors that are important here, so this is a study of clinicians who are working with people who had experienced significant trauma. So looking at 2 variables of compassion satisfaction and compassion fatigue, it was social support that was positively associated and significantly associated with this notion of compassion satisfaction, whereas work hours were inversely related. And when it came to compassion fatigue, the positive correlation was between therapists' sense, no, sorry, it's not, it's hard to read these slides here. Therapist's sense of powerlessness. Can't quite see, I'll have to put the magnifying glass on whether that was. So therapist's sense of powerlessness is positively associated with compassion fatigue, as was work drain, emotional self-awareness. So that was negatively associated. So those who have some level of insight, so that being a protective factor, whereas the clinician's own trauma history was positively associated. So one of the conclusions being that social support was one of the most significant factors associated with compassion satisfaction. Thus, therapists may wish to reflect on how much time they leave for socialising, leisure and or hobbies they are allowing for themselves to recharge after working with traumatised clientele. And I think I've chosen this study because often it will be young people who do have histories of trauma that might not necessarily lead to a diagnosable PTSD condition, but thinking more broadly around notions of complex trauma and interpersonal trauma, often these things can be simmering away and can really drive depression and suicidality that isn't necessarily amenable to kind of easy treatment. And so providing messages and support in the longer term is kind of quite important in that sense. So one thing I'd advocate is that all clinicians have attention to some level of self-care, but that this is broken up into different aspects of this pyramid. And so at the base, that there's something that we're doing on a daily basis that keeps us ticking over, that keeps us grounded or helps us to manage stress, and that will be different things for different people. Excuse me. And then also thinking similarly weekly, monthly, and then doing those special things annually as well. I think that's really a really important point to be mindful of. So in wrapping up, we at the clinic are doing a number of research trials, and so one of them that will be finishing early next year is the YODA-C study, where we're looking at whether fluoxetine and CBT outperforms placebo and CBT. And so that's going to be really informative as to the treatment model and where we take things, and to see whether is CBT sufficient in helping young people through moderate to severe depression. We've also recently sourced funding to see whether we can provide an online social media platform for effectively supporting young people with suicidal ideation, so we're looking forward to developing and testing that. And we've got an active project at the moment where we're looking at the association longitudinally between therapeutic alliance and suicidality. Today's been a real whirlwind tour of the work that we do. We do provide workshops where we go through our model in more detail, and so there will be some training courses coming up in 2017, so we'll advise of the dates in the coming weeks, probably early next year. And finally, the main resource that the clinic uses is the Mood Clinic CBT manual that's available for purchase. The web address is there, and Orygen will send it out. There is a fee for that one, but certainly the feedback from people who have bought it and used it is that it's quite a significant resource and quite helpful and very targeted to that youth age range. So there, my email is there, so feel free to get in contact should you like any of those resources, but you'll need to arrange for payment if you wanted the manual. So, so the next slide is questions, and I wonder whether we had any questions.
Absolutely. So back from one that was earlier on, I think someone was interested in the way that you presented that mood timeline and wondering whether there was software that you used to create that. I think maybe we just let them know that that's come from our edited manual, but maybe talk through how you would do that in a session with someone.
Great question. Thanks, Alex.
And particularly, sorry, if there's concurrent interpersonal events as well, how would you mark them on a timeline?
Sure. So we don't have any specific software, but we're thinking about how we translate some of the paper-based resources into e-resources, because that's what young people want, and certainly more amenable to use in session and saving and things like that. So the timeline that you saw was developed by our design team here, so the ones that we use in our session don't look anywhere near as fancy as that. But effectively, what we would usually do is just have a graph on a page that we draw, and then map out the months of the year, typically going back 2 years, and then get young people to kind of think about some of the key kind of markers of where they can remember events. And often, you know, you can think about school holidays or times like that to prompt their memory. And then once you've got a few of those, you start to kind of join a line and then see where things have been going as a trajectory. I worked with a young person who really effectively was able to map on some of the interpersonal things that were going on. And so that will be individual. So some young people will be able to recall in lots of detail, others won't. So, but you know, I think it's worth giving it a shot, because it can give very rich clinical information, which can be really useful in the treatment process.
Okay, someone also commented about the resources and worksheets, and obviously we showed examples of the ones that were in our manual, but we also know that they're also publicly available. If you look online, just there's a whole range of resources that you can find that are freely accessible. But also wondering whether you would make any recommendations about any mood monitoring or other apps that might be useful for young people with depression.
We don't use a lot of apps in the clinic because, unfortunately, we have a little bit of an archaic health system in which we're part of, so we don't have the means to connect with any of that information. Young people will often tell us about things that they're using, and that kind of differs on a case-by-case basis, but it's something that we're really keen to explore. We just need to work out a way of doing that so that health information can be kept track of, and that we can do that in an appropriate and confidential way and those sorts of things.
Great. So we've just got one final one that's come in just to ask about, you talked through those 8 practice principles and said that it was part of a study. Just wondering whether that, the write-up of those is freely available, or how people could find that.
It is, so feel free to drop me an email. I might go back to the slide with my email address on it, and so that was part of an open access paper. So even if you just were to Google development of practice principles for the management of suicidal ideation in young people, that should come up. But if not, drop me an email. I'm happy to send you the paper.
Thanks. And someone also did ask about the pricing for the manual, and unfortunately we can't give a definitive answer because sometimes we have some promotions or some sales going on. So I would just recommend that people do have a look on our website and they'll be able to find the current price for the manual. Okay, so I think that sort of brings us to an end of the questions. So I might just pop on to just wrap things up. Thank you, Simon. So I'd just like to say thanks again for the presentation from Simon today, and gave us a really fantastic run through of a whole range of issues that we need to keep in mind when we're working with young people with significant levels of risk or significant levels of severity with their mood. I think the really important thing too that I took from that in the closing stages, which I'd like to emphasise first, was about the importance of self-care for clinicians, and maybe it's perfect timing with sort of holiday period coming up, and a lot of services that you work at will have a short closure time to actually spend a little bit of time thinking about how you are going to be looking after yourself, and make some commitments to doing that in the new year as well. Also like to reflect on the importance, as Simon highlighted, of considering the developmental aspects that are associated with mood disorders in young people, and the importance of involving families, not only in the understanding of why a young person might be having current difficulties, but also to draw on them for support in treatment when appropriate. And also the idea of considering or working with young people and really focusing on engagement in those early stages to understand a young person's complexities with a whole range of psychosocial difficulties or challenges that they may be facing, and the importance of sort of monitoring their suicide risks and working with that. And last of all, I think probably another interesting thing that I took from today was the importance of considering theory-driven approaches, not only to treatment, but also to considering, as Simon explored, how suicidality may develop and be maintained. So that's also really quite interesting as well, to think about how do we ensure that in our work that we're doing, that we're drawing on as much available literature and understanding of the developmental issues and why things have occurred from a theory-driven perspective too. So I'd just like to again say thanks to Simon, because I think it's generated a lot of interest, and we've certainly had a lot of questions and comments coming in. As he mentioned, if anyone's got any further things they would like to follow up on, he's provided his contact details. And I'd also just encourage people to have a look at our additional resources. So Simon talked about some of the training that the Youth Mood Clinic will be offering, but here's also where you can find some of the training and resources that Orygen, the National Centre of Excellence, will be offering over the next few months as well, including written resources and also training and all our webinars that I mentioned as well. So here you can find some things like research summaries, mythbusters, clinical practice points, fact sheets, and some online modules as well, and all these are available free. We've also got a couple of workforce policy papers which are available on the website as well and open to comments and feedback. So I'd be interested to see what people think of these documents and to have some input into how they may be applied more broadly. And as I mentioned, that was our last webinar for the year this year. So we've got a few more coming up next year. So we'll confirm all the dates very soon, and they'll be available on our website in the training calendar. But we've got two themes that we're exploring in the first half of next year, looking at anxiety in young people and also sexual and physical health, and how that's related to mental health in young people. So you can see the topics that we'll be covering over the next 6 months. So I'd like to thank you once again for your attendance today. We really hope that you found this information valuable, and we welcome your feedback at any time as well. As I mentioned at the start, this webinar has been recorded and it will be available on our website in a couple of weeks. Though having said that, seeing as we're leading up to the sort of Christmas closure period, it might not be to the new year. And you'll all receive an email when it has been uploaded onto the website, and your certificate of participation and an evaluation will be sent to you shortly, and we appreciate your feedback. So please take a couple of minutes to give us some evaluation on today's presentation as well. So thanks once again, and I wish everyone a safe and relaxing holiday period in the spirit of what Simon mentioned about clinicians needing to look after themselves, and we look forward to you joining us for more webinars next year.